Hello, everyone. Greetings. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around the land. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to Bright Spots in Healthcare, these live webinars drop into the podcast feed most Friday mornings. We record live on Thursday, drops on Friday. I encourage you to subscribe to within your favorite podcast app, get access to all of the great leaders that come on the show and provide their bright spots. Many of their ideas throughout the last couple of years could effectively help you do your job and impact the members or patients that you serve. So I invite you to do that. And if you do enjoy the show, it helps us reach more people, more leaders like you, if you leave a comment like this one from Maureen Pike, Director of Social and Clinical Care at Trinity Health. Bright Spots draws in high quality speakers and stays on the industry's hottest topics. Great speakers like the ones you see in front of you today. We have an incredible panel for you to talk about a really important topic, navigating the intersection of health equity. Excuse me, that's not the title of the show. Innovative strategies for health plans to mitigate social risk. Really excited. I prepped with all these guests. I know exactly kind of the directions we're going to go, and I'm super excited for this episode. Our sponsor for today's episode is none other than Socially Determined. They provide a social risk data analytics and expertise to healthcare organizations seeking to understand how social determinants of health and social risk factors impact all the communities that you serve. I'll tell you a little bit more about them later on in the show. We also have their CEO and founder, Dr. Trevor Williams, on the panel today. You could check them out at sociallydetermined.com, by the way. So let's start. And I'll introduce each one of our guests as they come on. Our producer, Sherry Keels, has posted a link to their bios in the chat if you're watching me live. And if you're listening to the podcast, it's within the show description. I'm going to start with Ellen Kelsey. She's the president and CEO of Business Group on Health. So really cool perspective that she brings. And so, Ellen, first of all, can we just level set? What is social risk? And then how are all the employers that you work with, how are they thinking about social risk?
Yeah, well, thanks for having me. First off, it's a pleasure to be on this panel with this awesome group of colleagues on a really important topic. So I appreciate you having me to bring the employer perspective on social risks, also sometimes referred to as social determinants of health. And just really simply, those are the circumstances in which individuals are born and live that often impact very directly not only their physical health, but their mental and emotional well-being and their overall quality of life. Often when individuals think about social risk or social determinants, there are a number of factors that come into play, things like their early childhood, where they were raised, their education, as they advance through life, their employment status, their income, and then all throughout their life, their access to food, housing, transportation, access to healthcare, and also increasingly coming into the conversation, very importantly, things such as racial and gender diversity and factors that can influence all of those earlier factors that I just mentioned. Lots of reasons why employers are focused on social risks and social determinants. Obviously, as I mentioned early on, they very directly impact physical and emotional and mental well-being. Employers have invested quite significantly in the health of their workforce. Employers are also very concerned about corporate social responsibility and addressing health inequities within their workforce, broader D&I and B initiatives. So we've seen increased focus from employers, not only because of the physical and mental well-being, but because of broader corporate initiatives over the recent years as well. We've surveyed our members specifically over the past 3 years in this area, and we have seen year over year steady growth and focus on employer initiatives aimed at all of these social risks. And in fact, one of our more recent studies is showing that addressing social risk or social determinants will be one of the top areas of focus in well-being programs for employer programs over the next 3 to 5 years. So steady growth over the past few years with more growth to come in the next few years ahead.
Ellen, what's behind the improvement?
I think lots of different things contribute to it. I think just awareness, first and foremost, of employers becoming more aware of just how extensive the needs are within their workforce across all of those dimensions. It wasn't that long ago that employers realized that they had as many people working for them that perhaps were homeless or did not have access to food, weren't making perhaps a livable wage, didn't have transportation to get to the doctors, right? So I think there's just broader awareness of truly the extent of the need within their workforce. I think also there's better data. So they are getting their arms around not only the extent of the need, but more targeted areas of need within their populations. And I know other panelists can talk about their capabilities in that area. And then also, I think, increasingly important as employers think about solutioning around this, they now have capabilities within their vendor partners, their health plans and others to help them address some of the gaps and areas of risk. So I think for a lot of different reasons, we're seeing the increase.
So we see an increase. One of my a recent quote that was given to me or said to me that really just caught my attention is like the most valuable resource we have as human beings is our attention, like giving something our attention. So employers now are not only aware of it, but they're paying attention to it. So that's one of the reasons we have an improvement, that focus. And the second is there's a lot of companies that have emerged that are good solution providers to partner with employers and plans to be able to provide better data, better solutions. Did I summarize that?
Yep, that's spot on. Yep.
Okay. That's awesome. Thank you. I want to pivot to, let's get behind the scenes on some of like the innovations that's happening at employers and health plans. And I'm going to bring in Shantanu Agrawal, Dr. Shantanu Agrawal, the Chief Health Officer at Elevance Health. I'm going to see how many mistakes I can make today before the hour's up. So Shantanu, welcome to Bright Spots. And how are you guys thinking about and innovating in the area of social risk, and how are you leveraging that innovation into something of a tangible benefit for the healthcare consumer?
Yeah, thanks very much for the question. And Eric, thanks for the opportunity to be here. It's an incredible panel. I wanted to start maybe by just building on what Ellen had said, because I think it's really important. We started this journey a few years ago, and one of our first steps was to conduct a survey of our members, including in our commercial populations, to really understand the nature of the social risks that they have. And to her earlier point, we found that 30% of our commercial members actually reported having 3 or more significant social needs, significant in the sense of food insecurity, housing instability, overall just sort of financial instability. So quite significant social needs, and those social needs stacked on top of each other and actually raised healthcare costs. We found in this analysis, right? Why? Because these members weren't able to go to their PCPs, right? Weren't able to get preventative and primary care. They were ending up in the ER and ending up admitted to the hospital. And so I do, try to make the point over and over, when we talk about social needs, we are not just talking about the Medicare and Medicaid populations. This is absolutely pertinent to commercial as well, for a host of reasons. And I think it is very, very business aligned for employers to think about addressing these social needs. In terms of your question, Eric, about innovation, I think really what needs to happen is creating end-to-end solutions where you can use data upfront to understand what social needs are. And just given the state of the art today, I know our other panelists can speak to this. That data is still really challenging and hard to come by, but progress has been made. I think once we understand social needs, it's really about creating an infrastructure for getting those needs met. For Elevance Health, that can be first leveraging our own benefit design, things like supplemental benefits, value-added benefits, and then ultimately also leveraging community resources by working with community-based organizations. That's really what needs to happen, right? It's sort of that end-to-end solutioning, and totally happy to go into more detail.
So before we get into some of the tactics around providing care and that benefit design and the supplemental benefits. Let's talk about sort of in the theme of aim, ready, aim and fire, right? Like, so how are we figuring out where to go, where to think about where those resources need to go, and what's Elevance doing in that vein to aim?
Yeah. So one the things that we created, we sort of created this tool called the Whole Health Index, which is really a member level analysis of what is driving a member's whole health, right? And this is very tied to our overall strategic goal and mission around addressing whole health. So, bringing together physical, mental or behavioral health and social health into kind of one assessment, which is the Whole Health Index. I come from a quality improvement and measurement background, and frankly, one of the challenges in healthcare today is that despite the fact that we have a lot of measures, they tend to break health down by condition or by organ system. And it's really hard to aggregate up and get that macro level view of just how healthy is a person. And so that's why we created the WHI. It was really important to us that social be part of that. So it's one of the core components of the index, because we know that social health or lack of it highly correlates with overall health and health outcomes. So we created this index. We've calculated it for every member that we have, 45 plus million members. We sought validation of the index. We worked with an external company, a statistical company, to make sure that the index was valid and reliable. We have published on it in the New England Journal of Medicine Catalyst. The goal there to be, total transparency about what the index is, and if others would like to use it, obviously encouraging that. And that WHI has really guided a lot of our efforts, kind of following it, to better identify members who need more support, as well as the kind of specific support that they might need that we can then investigate directly with them.
Yeah, I love that. And Sherry's going to post a link to that Catalyst New England Journal of Medicine abstract if people want to check it out. We'll put it in the show description. Okay, just to put a bow on this a little bit, like what are the core components or the three pillars of this program, so people could get an understanding of it?
Yeah, great. So three major components of it. So there's an overall kind of the collection of all of the diagnoses that you have, right? So your overall morbidity is one kind of global health component, we call it. Second is an assessment of the quality of care that you are receiving. So are you getting primary and preventative care? Because obviously that's highly correlated with your health outcomes as well. And then third is that social component. It's the context in which you live. So is your community, food insecure? Are you likely to be food insecure, right? And again, I think it speaks to where we are in terms of the data. We have really good member level data in terms of access to care and the quality of that care, in terms of the overall diagnoses for an individual. It's that social component, and I know Trenner and others can speak to this, that really we as an ecosystem need to continue to improve upon so that we get that information as much as possible down to a member level. I often say, not getting social data and information from a member is akin to like trying to solve hypertension without taking any blood pressures, or having a blood pressure for a community, right? That's not going to cut it. We need to know what's happening at an individual level.
Okay, so first of all, WHI, it just basically simplifies the entire approach that the health plan can make to addressing this. So I love that. It's sort of the aim, ready, fire. It really gets you aiming and ready, right? And then as far as the pillars go, overall health based upon diagnosis, quality of care that they're getting, and the access that they have. And then, of course, that social context that you just mentioned.
Exactly right.
All right, I like that, and so I'm going to shift to another Blues plan in Blue Cross Blue Shield of South Carolina, and I know April, you also have a stratification concept, which leads to the ability to have targeted intervention. So let's talk about those. Like, can you tell us about how you've built care pathways, interventions, and how that's working to improve the outcomes? So the fire part of Aim Ready Fire.
Sure, and.
I'm sorry. I want to introduce you. Sorry, my bad. Again, another mistake. I'm having a belly of them. April's the Vice President of Clinical Services at Blue Cross Blue Shield of South Carolina.
Right. I was about to get it myself, but thank you.
Sorry about that.
Well, a few years ago, we were looking at the way our members engage in our care management So we have population health programs, we have some wellness prevention programs to kind of capture people early, and then we have our more acute programs like case management, especially case management for those that are, engaged in more of a crisis type situation, leaving a hospital, examples like that. And it was a pretty traditional model, but we wanted to really think about where we have opportunities to improve that. We know that healthcare doesn't occur just in these little episodes, and that there's a continuum of ways that members or individuals interact in the healthcare system. So we really wanted to have programs that met the needs of those individuals as they moved through the continuum. So we did a revamp, and we actually ended up with what we call our 7 levels of care management. I stuttered there because we would always say layers instead, like a 7-layer dip, but it was 7 levels of care management. And it went from the lowest acuity, those wellness prevention type, and then gaps in care, where we're just looking at those screens that people should be getting based on their age and demographics. And then, flows into episodic care, which is really someone that went to, surgery for a knee replacement or a hip, something that was pretty short term, but may need some coordination and care around that, or individuals that are just interested in what their benefits would cover. So a benefit management type episode, or, an overutilization of the ER where they really should be seeking primary care services, things like that. And then that flowed into our population health program. So those are our disease specific or condition specific programs. And we had those on a risk level of low, medium, and high. And then we overlaid that with a predictive tool that our data science team incorporated in, where it highlighted individuals that were at increased risk of a hospitalization. We looked through indicators in the claims that identified those individuals that had a chronic condition, but would soon be going to the hospital. And then we had our acute care levels, which are, case management, and then our specialty case management programs, which are more of our complex diseases like cancer, end-stage renal disease, and palliative care. So when we created this continuum, then that really opened up opportunity to overlay other enhancements. So when we were looking at how do we incorporate social risk and looking for the barriers that individuals are exhibiting because of their social situations, then we could overlay that risk onto this continuum and really get into personalized care plans.
So just so I'm clear, the 7-layer dip, right? The 7 levels of care management. Was that already in place? And what you did was then you amplified its ability to be more targeted through sort of your social analytics, or is it vice versa?
Well, we had, kind of population health, a condition specific or DM, management, case management. That was what we started with. And we're like, it's really more than that, right? There's really a lot more scenarios where a member will need to interact with our care team. And that's when we developed those and went through the process of really teasing out what are those different stages of care where we need to have a targeted program. And that's what led to the evolution into the 7 levels.
Great. I'm hungry. So the seven like measure. That's great. So how Trenner Williams, Dr. Trenner Williams, CEO and co-founder of Socially Determined. Trenner, how should health plans be thinking about this aim, ready, and fire for the different lines of businesses, whether it be ASO, fully insured, Medicaid, Medicare?
Yep. First of all, it's great to be on this panel with friends and pillars in the space. It's a bright spot, Eric, to your name that we're talking about this. I think it's incredibly interesting and maybe unexpected that in 2024 we are talking about this in the commercial space as much as we are. I know when we started Socially Determined 8 years ago, I really thought like this is individuals who have Medicaid, they're dually eligible, maybe MA, right? Because of reimbursement models is part of that. We actually have more lives on our platform that are commercially insured than any other line of business. I think that's a huge bright spot. One of the data points that we use when we're talking about perspective, and I'm definitely stealing Shantanu's hypertension example because that was awesome. But one of the things that we talk about is the number of minutes. April has seen me do this on stage, but the average adult in the US only spends about 63 minutes in an outpatient setting with a physician, NP, or PA in a given year. That means they spend over 525,537 minutes outside of that person's care. But the one place where they spend the most time is with their employer. And you think about the impact, and Alan, you talked about it. It's certainly healthcare costs, but it's also it's absenteeism, it's presenteeism, it's productivity, recruitment, retention. And in a challenging economic environment, right, that we're facing right now, like how do employers think about that? And it's less about maybe the clinical side, right, other than the connection to great, provider and insurance partners as part of that. There's a really interesting opportunity from the deployment of services or the connection into the community that employers have. I'll actually now get to your question, Eric, around ready, aim, and fire as part of that. Yeah. We actually use a similar sort of way to think about it, but we call it the what, the so what, and the now what as part of that. All of them are really important. A couple of things, though, even just to start, and I think about both Shantanu, you, and knowing what I do about your organization, and April, working with you all, and the governance, like the ability to have ownership, like at a central level, to have governance model, both data governance, but also organizational governance, how important that is to have a strategy. And April, both of you laid out effectively how you're thinking about this. And then how you engage all the other teams, right, and parts of the organization, because done well, and everybody on this call knows it, understanding social risk for the people that you have the privilege of caring for isn't like a side hustle, right? It's not a side of the table effort. It really is an integrated way. It's a brand new data set to be integrated. Both of you talked about that. Integrated with all the other robust data that organizations have. And so it's that commitment to being able to do that. That's the starting point. How we think about the ready, the aim, and the fire, that first step, that ready, or for us, the what, is the ability, and Shantanu, you talked about it, the characterization of social risk down to a member level, understanding a person's, both based on where they live, risk exposure, the assets and resources in a given community, but also based on their own personal situation, their risk for food insecurity, for housing instability, transportation, health literacy, economic strain as part of that. Being able to do that for 100% of your populations. And both Elevance and Blue Cross Blue Shield of South Carolina are great examples, because you've got every line of business covered, right? So one, that first step of looking across everybody, I think is consistent across lines of businesses and the work that you do. That's the first. The second, that so what, or the aim, is really important, because every organization, yours included, only have limited amount of time, energy, budget, people, priorities, right, as part of that. So you have to make really thoughtful, data-driven decisions about where you're going to place your bets, where you're going to make investments. And this is where I do think there are nuances related to line of business, right? So from a commercial standpoint, how you think about it and the metrics that matter, maybe about, first of all, retention of a customer base is part of that. And maybe secondly, about part of that retention is aligning members, employees who have needs, with existing benefits that are most likely to help them, right, achieve better healthcare outcomes, maybe lower healthcare costs as part of that, better employee metrics as part of that. But for MA, it's really different. Maybe it's around medication adherence and STAR measures, right? And especially with the Health Equity Index and the increased weighting there, being able to think about those metrics and measures at a member level, and where social risk, transportation, maybe finance, health literacy are creating barriers and people aren't meeting them. So the reason I bring that up is because I think the aim part and the so what is that integration, and both April and Shantanu talked about it, of healthcare data, disease, cost, utilization, attribution. So at a commercial level, at minimum, who's their employer, maybe more like job class or primary facility site. So you can think about doing really interesting risk stratification as part of that. So line of business allows you to think about that integration of the right healthcare data. That last part of fire, or for us, the now what, where the rubber meets the road, is really everything else is academic. Now it's, in Shantanu, you talked about having an infrastructure to be able to act. And is it like with ground game or find help and being able to get all the way out and connection to community-based organizations? Is it the use of value-added benefits, right, or supplemental benefits as part of that? So as you identify members, as an example, who have maybe live in a pharmacy desert and have transportation barriers, like being able to connect them, whether it's like to Uber Health and prescription delivery, right, or it's a script drop as part of that, and doing that full connection as part of that. So you can be thoughtful about the ready for everybody, the aim and identifying cohorts, and then the fire, right, to actually drive action.
I want to get into sort of the core pillars or components, the blueprint, if you will, to be able to enable an organization to do everything you just said around what, so what, and now what, or aim, ready, fire, whatever words you prefer. I'm going to come back to you on that, though, Chandra. I want to go into some strategy stuff and then come back. Incidentally, for those of you who are watching and listening to us live, in about, I don't know, 20 minutes or so, you're going to get another email from me. Congratulations. And it's going to be asking you for your feedback. This is where you can help us, guide us on the topics we're going to cover for the rest of the year and into next year. It's also a place where you could help us get better. And this is where you could say the moderator made too many mistakes. But we look at each one of those surveys from every episode. It's why we've been able to grow the show over the last 11 years. So we ask you in advance to do that for us, and thank you in advance for doing that for us. It takes about 2 minutes of your time to complete. Incidentally, around feedback, if any of you are going out to AHIP, I don't know if we have a poll for this, Sherry, but if we do, I'd love to meet with you. If you're going out to Vegas in a couple of weeks, and just to have a coffee or a beer and chat about healthcare, and also allows me to better inform the show and direct the show. Oh, you do? Great. So if you take that poll, if you're going to AHIP and you want to connect with me, let me know, and I'll reach out afterwards. So coming back to the whole health index, Shantanu Agrawal, Dr. Shantanu Agrawal is the Chief Health Officer at Elevance Health. I'd love to hear about how WHI fits into Elevance's bigger strategy, because I think that's important for everyone to hear, and that could give everyone some more color on how this is all kind of plays out at Elevance.
Yeah, thanks. Well, this really, I think, agrees with what Trenner laid out. What the WHI helps us do is identify members that we need to approach for a more detailed social and healthcare risk screening in order to connect them to the right resources, right? So we've leveraged the WHI in a multitude of ways. We've made it available to our case managers. So as, for example, they already engage in CM or disease management programs, they have the WHI at their disposal in order to better understand a member and then be able to dig in where the WHI is pointing, so it can help uncover issues that they might not otherwise know about and be able to inquire about those issues with the member. We've also used it to just focus our program. So we've created, for example, 2 programs. One is focused on the least healthy of our membership according to the WHI, and we enter them into essentially a case management program irrespective of their utilization, right? So the idea was, we believe they're not healthy today. Whether they've triggered a high-cost event or not, that could clearly happen. And so let's get them into a focused program. We started this a couple of years ago with initially 170,000 members, and we've been tracking them over time. The other thing that we did is we used the WHI to better understand groups of related members. In other words, families and households. Right. So when you take a member specific or line of business specific approach, you miss what can really be relevant and perhaps on some level obvious connections. The WHI allowed us to kind of recluster people because we found essentially households of people that were kind of equally unhealthy, or the same issues were kind of driving their health as you would expect. Right. I mean, if a mom is food insecure, her child is going to be food insecure in the same household, right? This is the kind of thinking that I think we have to engage in order to really optimize these programs, get to sustainability, and ultimately kind of drive all of the different areas of value that Trenner referenced. And I totally agree with his comments. So just a little bit in the way of outcomes. I mean, like I said, we've been running these programs now for a couple of years. We have found it is possible to actually improve someone's whole health, at least as measured by the WHI. Right. So in that initial cohort of about 170,000 members, we found that just about 9,000, we could actually get to improve dramatically such
Wow.
that they were no longer in the cohort. So they had such a rapid increase of their WHI in the space of about a year that we kind of graduated them from the program. We found that we could make incremental progress in an additional 130,000 members, right? So you can do this, you just have to focus on the right membership. And the primary vehicle that we used in order to improve the WHI was to get these members into a social needs program. And it was really, again, assess their needs and to the best of our ability, get them addressed. And obviously happy to talk more about the value drivers and how to make it sustainable for a company like ours. But I think for us, it was really telling that not only could we measure it, but by addressing social needs, we could actually get their health improve.
I want to see if I captured some of this. So you said of the 170,000 members enrolled, and that would include some of the related members, and related meaning literally related as a family member.
Yeah.
170,000 members are enrolled. You saw improvement in 161,000 of the 100.
Essentially, yeah, dramatic in about 9,000,
Yeah.
And then incremental in others, and then those members we've kept in the program, and overall we've actually expanded this program now to really just focus on the sort of essentially bottom quintile of our membership according to their health as measured by the WHO.
So does that mean that number, you launched it with 170,000 eligible members? Does that mean that number now is a little bit smaller because you're getting more, you're going to more specific?
Well, we actually are expanding the program, so it's bigger. We started by really the least healthy. I mean, like literally the lowest numbers on the WHI. And now we've expanded the pool of members that we're looking to intervene.
Okay, great. And now, and this is all part of your whole health improvement now program.
Yes, that's exactly right. Yeah.
WIN for sure, right?
WIN. Yeah. I mean, we're not great at naming stuff. I'll just say for the record, that seemed like a direct, yep, that's what we want to do is we want to improve all that.
I give you props for that one. I like that one. So you alluded this a couple of times about sort of making sure that there's interventions, and obviously you've mentioned community a couple of times. So if you think about, our focus over the last 6 to 8 years for sure on the social drivers of health, and really aligning with when Trenner started his company. I don't know if he caused this, but now this incredible enlightenment. But we're getting better now at aiming and getting ready, and then the firing. Sometimes we nail it. So it sounds like you're nailing it with this program. But obviously you need to go to the community and get local to do it. So, you're a national player. You just mentioned scale. How are you sort of aligning your aspirations with this WIN program to be national? And how are you able to manage? I think it's hard enough for a regional plan to manage a network of CBOs and work with them and figure out who's doing what and who's doing something well versus not so well. How are you approaching all this? And maybe what guidance can you provide a smaller regional plan listening right now?
Yeah, that's a really important question. So first, just to build on what Trenner said, I think you've got to get clear on what are the measures of success that are going to matter for your company, whether it's an Elevance Health or an employer that's going to move the needle and demonstrate for the enterprise what the value of these programs is in order to keep them on a sustainable footing. For us, obviously addressing cost of care is really important. And if we can root out unnecessary care, like unnecessary ER visits or hospital admissions, that is great for us. It's great for the member. So we look at that. Second, to Trenner's point, quality measurement is now squarely in this space. I would argue the Health Equity Index in Medicare, the HEDIS social needs measures, they're all pointing at plans and others doing these assessments and interventions. So that's an incredible value driver for us. And then I also think a lot about just member perception, right? I do think as an engagement mechanism, assessing somebody's social needs in an empathetic way and working to address those needs can be hugely important for a member. And just imagine the level of engagement they'll be willing to have with a health plan if we kind of do this quote unquote non-traditional work. So those are the value drivers I think about. What we have done is partner to your question about working with CBOs. CBOs, look, most of them are small, they're nonprofits, they're very local, they're in very, very specific, not just communities, but neighborhoods. and working with a large health plan. And for them, it may not matter if your health plan is a single state plan or a national plan. You are a large entity in their perspective. Working with them can be challenging. And so what we have done is actually partnered with some strategic partners in order to create CBO networks. They will do the contracting. They will work on data exchange platforms that are HIPAA compliant, that meet all of our regulatory requirements, but in a way that is not burdensome to the CBO, because they have, CBOs are not equipped and they're not resourced to handle this kind of burden. And so we have to take it off of them as much as possible. And we've chosen to do that through strategic partners that, that is their main area of focus, is creating these network of CBOs and then getting data exchange between plans and CBOs.
That is unbelievable. I want to summarize a little bit of what I heard there. So the value drivers for you guys are the measurements coming down from CMS, pushing us to measure around SDOH and have solutions in place. And there's going to be value there now, today, with some of these incentives, and you anticipate probably moving forward. And also, something else you said that I think is really important, independent of CMS, is it creates a unique opportunity that, if done correctly, if you leverage these non-clinical variables correctly and you're able to engage in an empathetic way, you're going to get better participation from your membership in their healthcare in a way that's not being seen today.
That is exactly right. And when I think about it from Ellen's perspective, for example, employee productivity, employee engagement, I mean, those are the kinds of things that I would think about to demonstrate, again, the importance of this kind of model and why it matters to an employer.
And as far as really maximizing the leverage you could get out of all these CBOs out there in your market, try to find a partner to help do some of that hard work for you. Boots on the ground organizations that could aggregate the best CBOs for you is what you guys are doing in all the markets around the country that you're in. Great.
Yeah, exactly right.
Okay, we're gonna get. I want to circle back to Ellen Kelsey in a moment and talk a little bit about self-insured employers. Before we do that, I do. You've heard sort of the great conversation. I want to give you a little bit more info on socially determined. I believe I want to say it was 2018 at a conference in Dallas that I met Trunner for the first time, and immediately he made an impact on my memory, because we talked about some really cool things around maternal health. You probably don't even remember this, Trunner, but
Of course I did.
You bothered me at that high top table trying to get work done. Anyway, the organization that he has founded is doing some incredible work around social risk, data analytics, and expertise in healthcare. And I do believe that socially determined has helped pioneer this entire category in a way that no other organization has. And I would say that whether they were sponsoring this episode or not, they have a platform called SocialScape, and it provides actionable, right? We said aim, but it actually fireable, it targets actionable insights into the community at a community level, where you could get. You heard about that information, about getting information on each individual in your membership. They give SDOH risk exposure and individualized social risk factors for each member in your population that could really impact their healthcare utilization. They allow you to be much more sophisticated in everything you do, not only around targeting potential high-cost claimants, but around engaging appropriately, creating more participation amongst your employees, your members, whoever you're trying to target, providing more equitable access, and all the things that are going to eventually improve your scores around CAHPS and STARS and HEDIS, and also improve member satisfaction, retention, and lower cost outcomes. So I highly recommend you reach out to these guys. Trenner is a great guy to just talk to. And if you fill out that feedback form, I'm happy. There's a place where you could literally request to be introduced to them, and I'm not just going to pass on your name. I'll make a formal introduction through email and connect the two of you if you want to just pick Trenner's brain and get some insights from all the smart people working there. And incidentally, in preparation for today's episode, I got to read an incredible article, we'll call it a white paper article that they wrote at Social Determinant on how to precision target your populations in 2024. It's not overly promotional, I promise you. I won't be providing it to all of you. If you want a copy of that, I'm happy to send that to you after the show. So we'll put up a poll there and you could request it and I'll send it out to you directly. So I want to bring back Ellen Calisay. She's the president and CEO of Business Group on Health. And Ellen, how are your self-insured employers innovating around social risk mitigation, and maybe even provide an example? We've heard some health plan examples. I would love to hear some employer examples.
Yeah, I love all the examples that have been discussed already. You know, I think as I was thinking about this, one that I wanted to pull forward is around food access and insecurity. I think there's an awful lot that's probably more obvious that employers do around healthcare access and addressing financial needs within their workforce. Food access and insecurity might be, you know, less well known about the role that employers can play there. And there's an awful lot that employers do in that space. Certainly they have healthy food on site, healthy vending, you know, cooking demonstrations, and many employers are also offering subsidies or food pantries for their workforces. So there's a lot specific to food access and insecurity. One employer, an example, has a grocery discount card program where every week they preload a discount card for all eligible employees of $50 a week to purchase healthy foods. And that card is swiped at participating grocery stores and they automatically get the $50 discount applied. That's weekly to their groceries for purchasing healthy foods, fruits, and vegetables. Additionally, that employer offers an additional 25% discount to those on their workforce who earn less than $50,000 a year. So they're addressing, you know, not only the food access and insecurity, but those who earn less are getting an added discount on top of the 50% already offered to all eligible employees. So just one example of, you know, an innovative way an employer is really trying to address food access and insecurity within their workforce.
That grocery card discount, is that you're using obviously a third party they're probably using to identify, and there's certain foods that qualify for that discount versus certain
right.
foods?
Yep. There are foods that qualify. They use a nationally recognized, I'm not sure the name of the vendor, but a vendor that ranks, you know, the top third healthiest foods. And the grocery stores that have those foods are participating in that $50 discounts applied upon checkout when they purchase
So that person goes to, let's say, Whole Foods, for example, and they kill it with good stuff, $50 a week off their bill.
That's right.
On that.
Yeah.
Great. I cut you. Was there something else you were going with too?
No, go ahead.
No, I just wanted to get some clarification on that. Any other examples that you could bring into this food, whether it be something around transportation, something around housing?
Oh, sure. Yeah, lots of things that employers do around transportation, housing. You know, I'd mentioned income. You know, I think often when folks think about income, the first thing is, well, let's pay them a livable wage. You know, so really focusing on just, you know, the earned wages as a starting place, but then also, you know, for low income employees, access to earned wages in advance of payday. So there are lots of things employers that are doing to pull forward access to those funds, that they're not having to wait every week or every 2 weeks to access their earned wages. So certainly a lot in that space as well. You know, I think when I think about the healthcare and access to health services, that is probably the area where employers have probably made the most progress. And I think it's also because they've got a lot of good partnerships, as we've heard already through, you know, some of the plans here on the call today. Health plans have made great strides in working with employers to address, you know, social risk, and in particular, access to healthcare services among those. So lots of great bright spots relative to that particular risk as well.
So if we were going to make you a CEO of a health plan for a day, when you're thinking about some of these benefits that you just outlined, whether they be the access to health services, and we can get more specific there, or maybe it's the food access program, like how would you recommend a plan who's listening in the audience to think about building a similar program? Is there a recommended roadmap that you could talk about, or just some guidance on how to take some of those things and create a supplemental benefit program?
I would love for the health plans listening to follow the roadmap that we've heard already from Shantanu and April. Not all health plans are doing what they're doing, right? So I think there are some really good examples for other health plan leaders to follow. Really just around the data, first and foremost, access to data, longitudinal data, understanding the member population. providing employers with actionable insights about the data that can be actualized and acted upon. I think one of the points that was made earlier was, connecting members to the programs that already exist. There is a lot that is already out there that people are probably not aware of. So it doesn't necessarily mean curating a new solution or a new approach. It's just connecting dots between the needs and programs that already exist. So I don't mean to imply that that's easy or it's low-hanging fruit, but I think that there are, some really good models, as we've heard about on this call, for other health plan leaders to follow. I think certainly I couldn't be on a call like this without talking about just macro level healthcare affordability and quality of healthcare. And so certainly if you are a health plan leader, all that you can do to address the macro level affordability issues will just, rising tide floats all boats, and will certainly help not only employers, but also, their members with these other social risks. And I think access, certainly we talked about, I think Trenner used the example of a pharmacy desert. We know there are lots of deserts related to whether it be pharmacy or maternal health, what have you. So I think if you are a health plan leader and you can address access issues within your membership, that will go a long way in terms of addressing all of these risks.
I want to get to a few more examples from health plans in a moment, and we're bringing April next. Quick PSA for everyone. Our next live show, we're not doing a live show next week. We're doing one on June 6th, 12 o'clock, same bat channel, 12 p.m. East Coast time. It's on Investor Insights. We're going to have a bunch of VCs and human capital experts on to talk about strategies to drive transformation growth in healthcare. It would be a really interesting show about talking about growing and scaling your organization. Then on June 18th, and this is not a Thursday, so it's a little unusual for us. Mark your calendars for this. We have an episode on home and hybrid care. It's a part of it's a summit. It's a half-day event, and it's something 10 a.m. to 1 p.m. East Coast time on a Tuesday. It's called the evolution of the virtual care category. So you guys all know virtual care is dramatically changing, and we're co-producing this with our partner TitlCare for that. And if you want to us to register for that event, we'll put up a poll right now. And then on June 20th, the convergence of pharmacy and health equity, right in line with this topic. We're going to talk about HEI and pharmacy 2024 and beyond. So lots of programming coming your way, all live throughout the month of June. So I'm going to bring in April Richardson, VP of Clinical Services, Blue Cross Blue Shield of South Carolina. April, we were just talking about examples, and our CEO for the day, at least for a health plan for the day, Ellen Kelsey, mentioned that you guys are a great example. So what are some of the fundamental pillars that Blue Cross Blue Shield of South Carolina has in place around the social risk strategy?
Yeah, so it's an evolution. So we're hearing a lot of demand from clients, and we're seeing it pop up a lot on RFPs and RFIs about what is your health equity strategy, what is your strategy to address social determinants. We are also inspired by some of the other Blues plans that we were hearing from that were in the forefront of incorporating social barriers. A few years back, they did a lot of highlight of this on our Blues Association summits. And so it really gave us, the fire to figure out how we want to address it within our own plan. So we started small, and I think this is, you can do this kind of grassroots style. We started with open access information. So we were looking at the Social Vulnerability Index, which is based on census data, and it's openly available for individuals to use. And so our data science team brought in some ways for us to visualize that across our population. And we created a risk score within our the health record that we use for documentation, and what is used to triage and stratify our members that are identified for clinical programs. So we brought in those just free open access risk scores first. Those aren't the most specific, it just kind of looks at where the people live, and in that community, what are the risks that those individuals typically have. So it's not going to tell you what Sam Smith's risk is, but it's going to tell you what all that neighborhood around Sam Smith looks like. So we started there, and we started training our nursing staff and our clinical staff on how to do proper assessments for social risk. We use the PREPARE model for that. And so that's an acronym. It's the let me look at it, protocol for responding to and assessing for patients' assets, risks, and experiences. So they have a really detailed map of like how to incorporate assessment into a workflow. This is typically done in provider practices, but we adopted that into how we would use that as a health plan. It also has a lot of information on how to train your staff on asking those culturally competent questions. So we spent a lot of time with that training because this was a little different for some of our nurses who were, long timers in health insurance work, and they just weren't used to asking these types of questions, thought it may come off as offensive or that people wouldn't feel comfortable responding to or answering those questions, or they didn't feel comfortable even asking them. A lot of that, what we already talked about, the misperception that commercially insured people don't have social barriers that they're dealing with, which is a complete, misnomer. Obviously, we've talked about multiple examples where commercially insured individuals have a lot of barriers that they encounter related to social risk. So we did a lot of that legwork using those open access and free to use tools. Then we also use that for resource matching. So Aunt Bertha, which now is called Find Help, is open access resource matching for community behavioral organizations or community-based organizations that can help with that. And then we built our own. So we have an access database where we looked at all of our other CBOs and incorporated information about, who they fit best with, like what access they have and what resources they provide. So we use some combination of both of those. And then we approached our bigger corporation and said, look, like this is what we started with, but we think we can get better. And it would be a lot more specific and impactful if we could use member-specific risk scores. And that's where we, matched with Trenner and Socially Determined through an innovation matching group that we're part of called the Health Plan Innovation Roundtable. And so we started those conversations and ended up, moving forward with a contract with them where we now purchase that member-specific risk scores to make it a lot more specific to each of those members when we do that stratification.
Okay, let me summarize a little bit. I'm not going to try to do that abbreviation and acronym that you mentioned, but I'll try to summarize everything else. So first, it's about targeting. So the social vulnerability index starts there. Then it's all about training the RNs and putting a program in place there to allow them to be more culturally aware and culturally competent, asking the right questions in a way that's empathizing with their situation and not insulting anyone, which is sometimes not easy to do. And then that open source resource matching you mentioned, and along with your CBOs that you have in your database, and then this member specific social risk scoring that you do thanks to, in part, to Socially Determined.
Yep.
Beautiful. That's great. Trenner, I want to see if we bring in another example of a health plan that you could share and maybe we'll dive into sort of the core components of what makes their program so effective in mitigating social risk.
Yeah, just a couple of things too, because the last three sets of comments were so good. Ellen, part of what you said too, it's a great reminder that this is a team sport, right? If we are all trying to solve this independently with all the resources that we have as a health plan, as a provider organization, as employers, as the government, we're going to fail. And so the opportunity to think, and a lot of times I'll talk about being egocentric in healthcare as a doc. A lot of times, unfortunately, I think of people as patients, right? Plans might think of people as members, their employer as employees. It's the same population. If we're going to actually move this needle that it's hard to do, it's like, how do we actually work together and get the best out of each stakeholder in the role that they can play and maximize that value? I do think that, especially like in the employer, the link between employer, broker, and health plan as part of that, and then how you best support that, I think gets really interesting. Both April and Shantanu have talked about great examples. I think about another Blues plan that we have the privilege of getting to work with, Care First, who is in the Mid-Atlantic, but they also, like most plans, have representation across the country. One of the initial really first pieces of work in their commercial population was with a Mid-Atlantic based employer, but had facilities in multiple parts of the rural America, and specifically wanted to look, and we found really huge spikes related to transportation and health literacy, those folks in, and Ellen mentioned some like provider and pharmacy deserts as part of that. The good news was that CareFirst has a really thoughtful and robust virtual care program. And so that opportunity to be able to now pinpoint ahead of time. So rather than waiting for, and I think this is part of why sometimes from a commercial standpoint, right, you have lots of benefits. I do too, right? That are available to me. The likelihood that I independently take action, both am aware of and take action, is frankly pretty low. And so what we found is if we can use the insights and in a data-driven way on the front end, you can start to proactively identify individuals who would likely get the most value. And in this case, it was the utilization of an available benefit around virtual care for those people with high level of, again, transportation barriers, without a car, and living in provider deserts as part of that. I think it's a really effective, simple way to do it. Another quick example, national employer working in 38 states, explicitly found, sort of highlighted massive food needs. And Ellen, you gave really thoughtful example about from a food insecurity standpoint. This organization had 3 distribution centers in Memphis, most of them below 240, the Interstate 240 is part of that, and real huge spikes related to both affordability and availability issues. And it both led to, and Ellen talked about it, sort of, how do they think from a corporate social responsibility investment into the community in those areas that will both benefit the community, but also benefit their own employees, and to making available fresh, healthy food available for people and taking advantage of proximity to the sites that they had as part of that. And they wouldn't have been able, it wasn't something that was on their radar prior to that. Food wasn't the highlight. So the insights from a data standpoint help to identify, again, that target area and the target population as part of that.
I like that. I like that. So could you just, identifying members who would likely find the right value, can you shed some light on like how that can be done? Because that seems, that seems in principle like, okay, common sense, but I think it's much harder to execute.
Well, I also think, again, transparently, I think when you talk to employers sometimes too, they will talk about, maybe they're more eloquent than this, but like a creepy factor, like how much does my employee want me to know, right, about them as part of that? So one of the ways, Eric, that I think very tactically is if you also get like either job class, job role, facility site, and you start to see, again, if you're using front-end analytics to be able to characterize the risk for every individual, you can then roll that up like to a job class or to a job role or to a site and say, we're seeing, in this case, like the employer I talked about, real significant spikes related to food insecurity. So rather than thinking I'm just going to direct a benefit towards Eric, but not to Ellen, instead, if you both are there, again, same role, maybe same location, I'm making it available to everybody. It does sort of 2 things. One, it removes that sort of creepy factor. I'm worried about getting too personal with somebody as an employer, but it also allows you to, again, with much higher likelihood, make those people who will get benefit both aware and available for that. And I think that's really important. I think on the health plan side, you do have a greater ability at an individual member level. I think both Shantanu and April have talked about much more targeted care management, even outside of disease, right? Just related to social risk. And I think you have the opportunity, again, in a proactive way to directly, again, target individuals in a positive way with benefits that can mitigate their risks and help them achieve better health outcomes.
Great stuff. Closing up on the top of the hour, everyone. I'm going to throw in one last question for our 2, well, we actually 3 clinicians on the panel right now, but I'm going to bring in April and Shantanu for this one. Shantanu, I know, April, I know you already saw this one, but I want to start, so I'll start with you. Regarding real-time data, member access and risk, this is from an attendee right now. I don't get the impression that monitoring vital signs and symptoms is as important for health plans as other data elements. Is this in fact the case? And can you comment on it?
Yeah, I was trying to hear it.
Yeah, I saw that.
I think both are important because we're focusing on both strategies. We want to have integrations with the practices and our health systems to get real-time information, discharge admission data, as well as through the CCDA files, which include clinicals like vital signs. doctors, I'm a doctor, so I know, we are not always good at coding everything perfectly. And so some of that information we can't get through claims, like obesity is one thing. So if we can get weight on an individual through those practice notes, like that is very important for us to be able to address those things. But so are these other factors that we're talking about. So when we get these,
It's not or, it's both. It's and.
it's definitely.
Shantanu, do you have anything to add to that as we close out here?
I totally agree with April. Maybe the one addition is look, a lot of practices and even health systems are not able to create the kind of infrastructure that a Blues South Carolina or that an Elevance Health can create. So it is really important as we think about more data exchange and interoperability with providers that we actually make these kinds of solutions available to providers as well, so that they can potentially utilize them. That's some, an area that we are working to get into now. It presents its own kind of challenges and process issues, but I do think augmenting the provider in this way is sort of a win-win for clearly the member, the provider, and for us.
Perfect. Thank you, all of you, for being so receptive to the preparation and everything you contributed today to our audience. I really appreciate it. And to everyone listening and watching, we do not take the hour you spend with us for granted. We know you're really busy. Thank you for trusting us with your time today. My message to all of you is, when you have a problem that looks really complex, really big, rather than looking for a massive cover to fill that massive hole, that massive problem, you may want to consider using the strategy of finding bright spots, things that are working well among all the chaos in our industry, and use those tactics to generate programs that could maybe come out to be an entire solution or solution strategy to your most pressing and toughest challenges, like providing more equitable healthcare access and mitigating all the social risk in your populations that you take care of. We hope you use the bright spots today to inspire your thinking and maybe even copy a few at your organization. We produce the show for you. Remember, this is your Bright Spots in Healthcare podcast. Thank you, everyone.